nutrition, lifestyle, and PED education. This is the Elite Strength Podcast with Aaron Scoffey.
Hey guys and girls, welcome back to another episode of the Elite Strength Podcast, number 14, here with Aaron Chacon, based out in Kentucky in the US. How are you, good sir?
Doing good. It's just another day in the life for me. This is where I live, the lab.
So how are things where you are in terms of, I guess, lockdowns and stuff? You've probably seen a little bit about what's going on down here in Australia and more so here in Victoria.
I am quite interested in how things are going. Here, at least, in the US, it's, we're pretty divided based on states. So at least here in Kentucky, nothing has really changed. They make me wear a mask when I walk through the hallway, and that's about it. It's not like what you see maybe in New York or California with really strict mandates. There's none of that there. I mean, life is kind of hasn't affected me any. So grateful for that.
Fair enough. So I guess a little bit about yourself, man. Like, what is it that you do, or what have you done and do? I guess is probably a good way to go about it.
So like we were talking earlier, I have a unique perspective. So originally I was really into bodybuilding, but I wasn't a very good bodybuilder, I'll admit, but I did like the science of it. And so I worked as a dietitian at a clinic for about 6 years, and they started throwing a lot of responsibilities on me, and which was a good thing. One skill that I picked up was I became a phlebotomist alongside. So I was drawing blood every day, more than I was actually doing nutrition counseling at one point. And I actually preferred that. But because of that bodybuilding background, a lot of bodybuilders came to me to do their blood work, and I would run everything. And I got to get some pretty good insight into what's actually going on with pretty high level competitors, amateurs as well, male and female, old and young. But I never wanted to stay in that clinical setting. So I was working on my master's at that time in nutrition science. So once I finished that, started applying to PhD programs, and I wanted to get out of the nutrition field. After a while, I lost a little bit of interest. I was more interested in pharmacology. I really wanted to know how drugs worked and do with them. So I joined a lab that studies primarily blood pressure, cardiovascular health, metabolism, and pharmacology, and circadian rhythm on top of all of that. Yep. So at least I do a lot of stuff involving drug timing, we call it chronopharmacology. And we look at how just by changing injection time or administration time, I should say, we see very, very different effects, profound effects, actually. And then that's a good spot to be in, because if you already have a drug that's FDA approved, already being sold on the market, and you can demonstrate that small changes in just a protocol, then you can make a big impact in effects on people. So that's what I'm doing now. Of course, there's a bunch of side projects that go along with it. But yeah, so now I do purely research, a lot of stuff on the biochemical side. And right now, my main focus is on blood pressure, but I'm also looking at cardiovascular health as a whole, some metabolism. And actually now, I'll be getting into Alzheimer's research. Really out of my comfort zone. But again, I like that sort of stuff.
Yeah, it'd be very interesting, I could imagine.
Yeah, interesting, difficult to study.
Yeah.
Really difficult to study, especially if you're talking about the brain of a mouse, right? It's really
yeah, for sure. Yeah.
So luckily we have a surgeon on our staff who's excellent at doing that sort of thing. So yeah, that's where I come from.
Sounds like fun. So when you said you were a bodybuilder, did you compete? Compete at all? Got into it?
I competed for maybe 6 or 7 years. In my early 20s, I was really into it. I thought it was my life's calling. I think a lot of young guys feel that way.
You're not wrong.
Yeah, and then you realize, you think you're invincible at that age. And you're pretty resilient at that age. You're not invincible. And, as I started getting to the clinical side of things, seeing people's blood work. And now that I'm really diving deep into it, I'm not willing to do the things it takes to be a competitive bodybuilder. For one, I know I wouldn't actually be good enough to, pursue it. I don't have interest in it. And I don't want to take the things you need to take to be competitive. So I'm done with all that. Last show I did was maybe 4 or 5 years ago now.
Yeah.
So I've
just training for fun and keeping
training for fun.
Yeah.
I mean, to me, I have no physique goals at this point. It's just kind of an escape, and just because I enjoy it. And oddly enough, my diet's pretty good too, but that's just some of those habits that come with.
I was going to say it'd be just repetition, right?
Yeah, repetition. And you take the good and you leave the bad. And
for sure.
Practice.
Well, just going to pick something out that you sort of just mentioned there, in that you don't want to do what I guess needs to be done. Yeah. Can you elaborate on that a little bit? And I guess your views and what you've seen, obviously, with your extensive work with blood work and, with a few different high level people. An idea, just for those that are listening that, might have that aspiration, or maybe they think they know what it takes to get to that level. Like, what is it that we're looking at, or, I guess a general idea?
Yeah. So, and this is a question I get, I say, maybe 12 times a day on Instagram.
Yeah, fair enough.
Yeah.
Right. Such funny enough, it's probably one of the questions I haven't asked you yet, right?
So it's usually the younger guys, right? I guess we could start with them. But the older guys who are getting into it also kind of fall. It's a pitfall, really, is you want to be good. You're very motivated, so you take X, Y, and Z, right? Testosterone and some other cocktail of drugs. And you get to a certain level, you think that's good. And so you think, well, if I have to get better, I need to take more. I need to try this and this. And it becomes a mentality. And, when you're young, it's not actually too bad. You can do some damage and get away with it unscathed. But it's when you fall into this pattern of having to take these drugs at higher doses or long term, that's where the damage really comes. And this is where a lot of people, they just don't know physiology. So bodybuilders, they like to cherry pick. I mean, everyone, right? But bodybuilders, especially in this regard, they like to pick the good, ignore the bad. They're playing pharmacist and doctor, and they have no understanding of pharmacology or physiology. Mm-hmm. So what I generally I try to keep it relatively simple, but you can only be so simple with these sort of things. There's 3 main things that all bodybuilders or anyone using exogenous hormones should pay attention to. They're simple: your blood lipids, your blood sugar, and your blood pressure. And actually how those all tie together is pretty interesting too. They're not completely in their own wheel.
They're not independent of each other.
Yeah. And what's good is you can test a lot of the potential threats that come with using whatever androgen or whatever growth hormone, whatever drug you're taking for performance enhancement. Know the risks. And once you know the risks, you can then test to see what's actually happening to your body. So I'm very much a proponent of objective analysis over subjective perception.
Yeah.
Too often people go by how they feel.
Mm-hmm.
Terrible, useless. But what's good about blood work and also other diagnostic tools, it doesn't just have to be what's in your blood, but a great example of your blood lipids is to get a coronary calcium score done.
Yeah.
That might be the gold standard for looking at what's actually happening around the arteries in your heart. But these objective tools give you the actual facts without bias. They just tell you what's actually happening. But, a lot of people don't want to face that reality. But if they do, I can give them a long list of things to check that your doctor's not going to check on your own. You would have to request this sort of stuff. And if you do, you can make reasonable decisions on how far you should take this, how far you should push it. And then it's up to you at that point, but at least you're being very objective in your decision making. You're not letting your emotions get the best of you, right?
Yeah.
And, if you've ever competed, dieting down, training hard, doing cardio, it plays tricks on your mind. You see the mirror and, maybe you look better one day versus another and can alter how you think. So that's the pitfall that I'm referring to. So, I guess for your listeners, that would be a good time to get out a notepad and take some notes. This is what I would test whenever I had bodybuilders come in. So again, lipids, blood sugar, and blood pressure are the three. We could probably throw inflammation as kind of an umbrella over all of that. But with lipid testing, you can get quite a bit done. I already mentioned the coronary calcium score. You should get done probably. Then this might seem a little extreme, but once you hit age 30, especially men, and every 5 years after that, if you are taking even just TRT, really. And what that's going to do is it's going to actually take a scan of all of your heart, really, and all the arteries around your heart. And it's going to show calcified plaque around those. And it'll give you a score, 0 to something. Well, I've seen some really high scores. The lower the score, the better. And that is your gold standard right there. That's something blood work can give you a hint at, but is not as good as this. And at least here in the States, it's cheap. I got one done when I turned 30. It cost me $100. Took 10 minutes. So there's no barrier. So I don't even think you need
No, I'm pretty sure here you can request them, but I guess you just can't request them like so often, like you said, every 5 years or 4 years.
Yeah, 5 years
okay.
is good.
But if you're doing it every other week, they won't do it.
Yeah, no, that would be. I get that mindset too.
I guess.
Fun. I mean, when I worked at the clinic, I would draw my own blood and check stuff.
That's a handy thing.
Great. Yeah.
Like we were sort of saying before, getting bloods is tricky, especially as a bodybuilder or as a PED user. Especially when you walk into the GP and you sort of say, look, I want this list of bloods. I use PEDs. The first thing they're obviously going to say is, don't use PEDs. It's like, well, right. We know that. Thank you for doing your job in that aspect. But next step, can you please give me this referral so I can go get these checked? And they just won't do them because they don't want to take liability for the results.
It's a problem. And it's been a headache, believe me. When I was coaching, I'd always have clients get their blood work, and boy, it was a headache, but there are little loopholes around that. Luckily, at least here in the States, TRT clinics are becoming pretty common. Yeah. And that's not to say that's a good thing, because there's a lot of bad TRT clinics, but that at least opens the door to blood testing. There are, at least here, there are places where you can just go get your blood drawn without a prescription, and you pay. It's kind of pricey, but you pay per test. So there are ways around it, and it is a barrier, but I don't think it's too major of one that would prevent you from at least doing this every so often. Especially if you're getting up in age. Age is probably the number one risk factor for all of this. So this advice probably won't pertain as much to a 30-year-old as a 40-year-old.
Of course, that makes sense.
Yeah. So at least what I would look for, sticking with lipids, obviously total cholesterol, LDL-C, it just tells you the general LDL count, and and HDL-C. That's as basic as it gets. That information's okay. It really doesn't tell you much. You also want to look at different parts of LDL, something called OB. That's good. You can think of it as like stickiness of that LDL particle. And for those who are completely unfamiliar, generally speaking, LDL is bad, HDL is good. It's not as clean cut as that, but for all intents and purposes.
To keep it as simple as possible.
Yeah, but if you want to dive deeper, you could look at SD-LDL, small dense LDL particles. That one is bad. We don't want that. A really bad one is something called LPA. This is a kind of an inherited form of LDL, and that's a big independent risk factor for a lot of cardiovascular disease. So LPA is a pretty good one to check for. On the good cholesterol side, we said HDL-C. Again, for listeners who are unfamiliar, you can think of HDL as kind of like a vacuum cleaner that sucks up LDL. Again, it doesn't work exactly like that, but generally speaking, high HDL levels are very good indicators of cardiovascular health. You want to get that nice and high. And when you're on testosterone, beyond physiological doses, beyond replacement therapy, and that dose can vary quite a bit, you tend to see LDL go up, HDL come down. We also see this when testosterone is too low. So by all means, you can be on a healthy dose of testosterone, and you can use these markers as a gauge for what is considered healthy. It's very individual. So HDL and LDL are good in that regard. ApoA1 is also good to add to an HDL test. You can think of it as like the strength of HDL to carry out all that bad cholesterol. And while you're at it, there's something called an HDL map that we can test now that will look at the size of different HDL particles. We want nice, big, fluffy HDL particles. And we've got a whole bunch of them. We name them alpha 4, 3, 2, 1, getting smaller and smaller. Pre-beta 1 is like also included in that. So it's not just the HDL count that matters, it's also the quality of that HDL. So that's good if you can test that.
I was going to say, can that be tested, the quality of?
Oh, yeah. I used to do it all the time. You would probably have to tell your doctor. I imagine the verbiage would be a little bit different, but we would call it an HDL map.
Okay.
And so you just think of it as HDL count is your quantity, HDL map is the quality. That's pretty good. And if you are still struggling with cholesterol being really high or abnormal, you can actually look at how this cholesterol is being produced by your liver. Mm-hmm. You can look at something called lathosterol, LATHO sterol. That's a good one, as well as desmosterol. Those two are big players in cholesterol synthesis. Okay. And if you see those levels really out of whack, you can actually do some things to kind of calm them down a bit. You can also look at how much, it's not entirely accurate, but it gives you an idea of how much cholesterol you're absorbing through food too. This is a controversial one.
Yep.
It's a big debate whether or not cholesterol in food impacts cholesterol. And
I wish we see all the big influencers talk about all the time.
And I just on my floor here, I've got two labs who study that very thing, and they both say opposite things.
Yeah, right.
I don't know. But regardless, you can test how much cholesterol you're absorbing with food, and maybe then you could balance out those production markers with.
For sure. Yeah. It's just more data to have, right? Yeah.
Yeah. More if you're going to do all of this, right? And it's such a hassle to get blood work, may as well.
Yeah, for sure.
And complete picture. So that would be a pretty solid lipid panel, right? It's not your basic lipid panel that looks at 4 things: HDL.
Yeah,
LDL,
it's going in depth.
You're starting to see the quality of it. You're seeing how cholesterol is working through the body. That's stuff that's really important for any bodybuilder, right? I think that would be sufficient to kind of put a check off the blood lipids. If you did that every so often, you would have a good idea of how these drugs are affecting your body. So
yeah, just a question, I guess, on using the sort of the lipid panel and the things, I guess, from a PED from a side of things that could affect lipids. So like you said, testosterone, even at HRT or supraphysiological doses could and does obviously affect LDL HDL ratio. What about other things like a DHT and a 19-nor? Like, what is it? I guess, you know what I mean? In terms of, everyone likes to use a DHT to balance out estrogen instead of taking an AI, which I guess is, probably progressive these days. But
So that's a great question. So whenever we're doing studies with like a testosterone study in the lab, we don't actually use testosterone because we don't want it to convert to estrogen.
Yeah.
So we'll use like DHT.
Yes.
And right now, actually, the person who sits behind me, she's running a project where she's trying to screw up lipids as much as possible and see if she can test that. And she's using DHT drugs to do that, actually.
Yeah.
So, what you could say is your body's not producing this stuff, all these exogenous hormones. And so when you take more than your body can handle, and who knows what that number is, it's probably pretty low, you're going to throw off a lot of markers in your body. And so you bring up a good point, is when you actually get these tests done matters quite a bit. If you're, 3 weeks out from a show, you're probably on a bunch of gear, probably on 5 or 6 compounds, you've been dieting for a long time, you're on the verge of death. I wouldn't use that as the best time to get blood work done. I mean, you could see just how much damage you've done.
It's kind of handy, right, to see how you're handling it at peak dose.
But it is an acute time. I mean, unless you're staying in that state for a long time, which there are guys who do that, and girls. So maybe if you're in that state for a long time, maybe see what damage is actually is being done, because this is where we see a lot of deaths happen. Right, this year has been terrible for deaths in bodybuilding. And it's not just one thing, right? It's not just blood lipids going awry. It's usually people tend to point the finger at electrolyte balance, hydration. I'm sure it's a combination of many things. Genetics play a role. Actually, there are kind of a few genetic markers you can look at as well. So John Meadows, who I always thought was a great influence for the bodybuilding community, supposedly he had some genetic predispositions to blood clotting and things like that. And you can test this stuff. There's a few genetic tests that might be worthwhile to consider. Now we have like 23andMe and those. I don't know how useful those would be to a bodybuilder. And I was actually at a talk all about epigenetics and genetic testing, and they just completely went off on how bad 23andMe really was.
Okay, right.
Yeah, so it's a very new area of research, so we don't know everything, but there may be a handful of genes that are worth looking at. Factor 2 and 5 Leiden are really good ones. So factor 2 will tell us whether or not you have an increased likelihood for forming blood clots. That is really, really important to know for a bodybuilder, because one thing I think we all know, right, is you see an increase in hematocrit levels when you take testosterone or DHTs or any androgen, really. You see a thickening of the blood, and that increases likelihood of blood clots on its own. You tack on these genetic markers, you're taking a risk. There's also factor 5, which is pretty good. This is a mutation in clotting factor in the blood called fibrin. And if you have this, it makes it harder for the clots to actually break up. So factor 2 and factor 5 are things that you should absolutely check. And probably everyone should check. Blood clots are pretty scary things.
For sure.
Other than that, someone recently asked me how statins would work for a bodybuilder. And, I'm a little conflicted with statins. If you look at long-term studies, they're not overwhelmingly positive results, but they're not bad either. There's actually a really interesting test called, I used to call it SLOCO-B1. It's SLCO1B1. This is a statin-induced myopathy gene. And basically, if you have this, your chances of getting side effects while on a statin will be much better. And the side effects from the statin can be just terrible. So if you are interested in statins or you've been prescribed a statin, they love to prescribe statins.
Yeah, it's one of the first things that they do.
Yeah, I mean, that's the go-to drug. Getting this this gene test is probably a good idea.
Yeah.
All right, so I think we covered lipids, right?
yeah. Like I said, it was just more, I guess, the influences of 19 Nors, I guess, as well, because a lot of people, do love trenbolone, for example.
Yeah, that screws it up bad.
Yeah.
So I'd say tren is probably the hardest hitting. Maybe don't quote me on that. It really tanks HDL. I mean, I remember testing this stuff and I would see HDL levels like 9 and 10 and 11, scary low, and LDLs would climb pretty high. Triglycerides too can be affected, and I don't actually quite know why. But there are some really cool drugs out there that are super effective at improving LDL and triglycerides that no one knows about. And I'm just blown away by it. One of my favorites is something called Repatha. It's a monoclonal antibody. And essentially what these are, at least our lab doesn't do it, but how a monoclonal antibody is made is you infect a mouse, a rat, or whatever. And you infect it, then you harvest the antibody from the survivors of that. You clone that antibody. And antibodies are unique and they're very strong in binding. They're very specific to binding things. So Repatha is really interesting because it inhibits something called PCSK9. I can't quite remember. It's like protein convertase something. Basically, what this protein does, it's an enzyme, is it degrades the LDL receptor in the liver. So if you degrade that receptor in the liver, you can actually increase LDL in the blood. So Repatha blocks that pathway. You get more LDL receptor expression on that liver, thereby lowering LDL in the blood. Yeah. It's a great drug to take.
Is that a prescription drug?
It is, yeah. But with this current crowd, I'm sure they could figure out.
Yeah. And I just thought I'd check if it's not something you can buy off like iHerb or something like that.
Oh, I wish. I mean, it's unbelievable. It's a little pricey. Monoclonal antibodies tend to be pricey, but they're good. I mean, that's the future of medicine. One of the futures of medicine.
Yeah, cool.
If your triglycerides are high, tren or a lot of these drugs, what's the common cocktail of drugs? Tren, Anavar, Winstrol.
Usually, I don't know. It depends. I guess I always hear mixed things, but I think the more popular one is like, one from each sort of family, and then sprinkle in a couple of orals just for fun. It's like test base, and then it'd be like a Masteron Primabol, and then throw in some Tren or some Androlone or, something along those lines, and then throw in, like you said, Anavar, Winstrol orals.
Yeah. So all of those, and who knows which one's doing what, but you would always see increased triglycerides, especially when fasted. And that's pretty bad. Basically fat in the bloodstream. And one drug that's actually maybe a little bit easier to take, and it's crazy to me that this is a prescription. It's called Vascepa, VASCEPA. Essentially, it's made from fish oil. It's made from omega-3s. So they added an ester to EPA, a really good component of fish oil. And they tend to prescribe this for people who have very high fasting triglyceride levels. And this drug does wonders at bringing that down. It reduces triglycerides in the liver. Also, it reduces VLDL. That's that LDL that we really, really want. Very low dense lipoprotein. I don't quite know how it does it. I was looking into it. I don't think anyone knows how it actually works. Oil is good, but in theory, but the studies that have been done on fish oil are not super promising. And that's not to say that the molecule itself, EPA, is bad. It's just maybe our route of administration or maybe potency, what have you. So Vascepa is kind of a strong, potent, very bioavailable form of fish oil.
Fish oil.
So the thought is, maybe it increases fatty acid oxidation. It lowers triglyceride synthesis. Maybe it increases the activity of a certain enzyme called lipoprotein lipase. So that's something I think is a little bit easier to get. And
just wondering, with these things, would they be something that you could take as a preventative measure, let's say, before you're going to get onto a bigger cycle? Like, are there any, I guess, detriments if you're already, I guess, we'll call it healthy? And, taking some of these things, knowing that, these things could potentially happen, like you're going to get higher triglycerides if you start using, a 19 NOR and just to prevent that, or would it be more, you need to take this once it's already high?
I would absolutely take it preventative.
Yeah.
I mean, and this goes with lipids, sugar, and even blood pressure too. Aggressive preventative measures to those three shows really good outcomes.
Okay, cool.
Basically, we just don't want to expose the body to a bunch of bad stuff all at once. And if this helps mitigate it, by all means. Vascepa, as far as I know, has zero side effects. It's fish oil. Right? By all means, you should be hammering that if you are going into a show. And part of me also thinks bodybuilders have this very limited mindset. They think the body is made of fat and muscle. But if you can understand just enough of the physiology to throw it all together, you would know that a healthy body will outperform an unhealthy one. So if you keep your health in check, I guarantee you will get better results. Fatty acid or fat loss, let's just say fat loss is different than probably what you've been told or what's been written in the textbook. It's very, very different, actually. It's complicated. And bodybuilders like to just break it down to calories in, calories out. And that's not wrong by all means, but it's limited. Right? There's a lot of other variables that go into those two parts of that equation. And if you can kind of have a holistic view and take health as the foundation, you'll get better results. I guarantee it. And you'll feel better. And you can do this longer. So sometimes that competitive mindset overtakes the logical one. So I guess that's why it's good to have a coach. Pull back. Let's actually, address this before we get too deep. Lipids, blood sugar. Blood sugar is kind of, I think bodybuilders understand blood sugar. It's becoming a little bit more mainstream now. Obviously hemoglobin A1C is the standard. That'll tell us blood sugar, an average blood sugar over the past 3 months or so. But to your point, if someone is, a few weeks out from a show or they want to see a very short period of time, you can actually see blood sugar over, it's like 2 weeks, I think. It's called glycated serum protein. And that'll give you kind of a short stint of where your blood sugar has been over the past few weeks. Another one that I think should be routinely checked along with hemoglobin A1C is adiponectin. It's a protective hormone, and it actually plays a really big role in regulating glucose and fatty acid breakdown. So that's useful information for a bodybuilder.
Yeah, definitely.
Yes, take that on. But that's pretty much it for blood sugar. I think nowadays they even have A1C kits that you can just order online. Your finger. That's good. Looking at
definitely.
Glucose is also pretty important too. We don't want that getting high. If that's starting to be high in the morning, something's definitely off.
Yep, for sure.
Yeah. So that's probably a good list of blood work to get. There's a whole bunch of inflammatory markers that are also worthwhile. And that's probably reserved for someone who's been doing this for a while and has had a issues already. You can there's like a ladder of different inflammatory markers you can look at. At the very least, everyone should get something called high sensitivity C-reactive protein checked, HSCRP, just a general marker of inflammation. It goes way deeper than that. If someone has those factor 2 and factor 5 ladens, they could look at fibrinogen too. That's an inflammatory marker. It's a sign of early inflammation. It'll kind of give you some insight into tissue or vascular injury, and maybe give you some insight into the potential of a blood clot forming.
Yeah, that's cool. And then in terms of blood pressure, I guess we sort of touched on lipids and blood glucose.
Yeah. So blood pressure is kind of my main focus right now.
I was going to say, I feel like this is the big one, right?
Yeah. And it's the scariest one of all, honestly. So when I worked at the clinic, I didn't realize blood pressure has a rhythm to it. All of these things actually have a rhythm to it. And I pause to say circadian rhythm, because that term circadian, there's certain properties. And as far as I know, blood pressure hasn't been proven as a circadian rhythm. We could say maybe a diurnal rhythm or just a day to night rhythm. But what's probably most important to know is that it's supposed to dip at night. It's supposed to dip at least 10% from your average daytime levels. So when you're asleep in the middle of the night, your blood pressure should be at its lowest point. And then when you wake up, it surges. This is a normal response. Again, it just kind of oscillates like that. But when it surges, that's actually when we see the highest rate of cardiovascular events occur.
Okay.
Most people get heart attacks and strokes. And that's what's really, really important to know when looking at your blood pressure. If you just check your blood pressure with a cuff and you don't care about the day or the time of day, whether or not you did this fasting or in a fed state, it's useless. It's not going to tell you anything. Ideally, what you would want to do is probably look at your blood pressure right when you wake up, maybe middle of the day, and then right before going to bed. And you could get those 3 time points, do that for several days in a row, average them. And now you have an idea of what's happening with your blood pressure, and you should see the pattern.
Yeah.
Obviously, you won't be able to check it at night. It's a shame. There are something called ambulatory blood pressure cuffs that inflate automatically, and they'll look at blood pressure 4 to 6 times throughout the day. It's really good data, but you have to wear this thing.
Yeah, I could imagine.
I don't think anyone will take it that far. But what is important to know is if that blood pressure rhythm is disturbed, you're in trouble. I mean, it's an independent risk factor for all sorts of cardiovascular events, everything from stroke to left ventricular hypertrophy, which bodybuilders are already at a big risk for anyway. I mean, we demonstrate that super, super easily. First off, athletes already have an enlarged heart. That's usually a very normal adaptive process. But when you start throwing androgens on top of that, there's a lot of androgen receptors in the heart.
Yep. People seem to forget.
Yeah. Again, the think muscle fat. Oh, am I going to muscle and lose fat? Well, there's off-target effects to everything that you do. And at left ventricle, again, so this is for people who maybe don't know much about the physiology. If you just separate your heart into 4 chambers, top being atria, bottom being ventricles, the left one is kind of what ejects the blood out. And if the walls in that start to thicken up, you have less room in there. On top of it, if your blood is thick from androgen use, any androgen use, sometimes even just low dose testosterone can cause hematocrit levels. Hematocrit is the percentage of red blood cells as your total blood. And if this starts climbing, usually if you start getting above 55%, you're going to want to donate blood. And that'll bring it down 7, 8, 9% or so. But keeping it safe levels is good. And once you start getting it too high, your blood gets thick. Just imagine it trying to pump out of that left ventricle that's already has a smaller compartment. That's bad. On top of it, this increases the pressure in what's called your thoracic aorta, the first kind of loop out of your heart. This aorta is this thick vessel that goes out from your heart, kind of like wraps around your back and goes down your abdomen and distributes blood throughout your whole body. And if you ever want to go down a rabbit hole of very scary information, go to PubMed, type in bodybuilders, aortic aneurysm, and you'll see a lot of scary data of aortas rupturing, because testosterone plays a huge role in the aorta rupturing. And it's not known exactly why, but there's a lot of research into it. And if it does rupture, especially lower it gets, like into the abdomen, you're going to die. It's 96% death rate, I think. It's really high. Very few people. Yeah. Thoracic aorta, they can usually catch it, and they can do on it. I have a friend who just had thoracic aorta surgery. He's on a cocktail of stuff. I mean, he's a classic, that pitfall I was speaking of earlier. More, right? He's on every single drug, and he looks terrible. Honestly, he knows, if he's listening, I'd be ashamed, but he knows he looks terrible. And sure enough, his aorta was starting to, it's called a dissection. It starts to literally start to tear. It's about to rip. Once it dilates to a certain point, they have to do surgery on it. And it leaves you with this big, nasty scar. So at least if it's up here, you can get surgery done. You can do it in the abdomen. It's a little trickier. That doesn't get caught. And we know that testosterone and blood pressure really play a role in that. And also with that comes naturally, you could imagine, inflammation and a high salt diet. And, whether or not the high sodium intake contributes to the blood pressure, we don't know which one's doing which. But yeah, I look at busted aortas every single week by injecting DHT and trying to cause aortas to rupture.
Yeah, you're on the other side.
Yeah, so that's why, when I said at the beginning that I am not willing to do what it takes to be a bodybuilder, this is why.
Yeah, it's totally fair, because there'd be a lot in there that even I wasn't sort of aware of, and I like to think my knowledge is pretty decent on this stuff. So. Yeah,
but with all that said, I do think personal choice and freedom of choice is still above all. Yes. And I'm conflicted, because at one point I kind of want to scare some people into not taking anything, because it shouldn't be in the first place.
Definitely.
But if there is someone who, is enjoying this, it's fulfilling, they're going somewhere with it, they actually have it planned out, they can actually take all of this advice and use it as a preventative measure. They can go and get blood work done. They can go and get these scans done. They can be aware a little bit about what's happening, right? All these drugs have off-target effects. You see blood pressure increase from the bodybuilding lifestyle in general. But how your body is able to adapt to that is kind of what matters. So it's just having that knowledge and being able to form a plan based around that, you should be fine.
So I guess my question when it comes to blood pressure, so things like angiotensin receptor blockers and that sort of thing, I guess, how do they play their part? More so, obviously, receptor 2 blockers. Yeah.
So that's kind of the big focus for blood pressure, right? So blood pressure is essentially cardiac output, how much blood your heart is pumping out, and total peripheral resistance, all the resistance that blood meets in the vasculature. And so angiotensin, or we should just say the RAS system, renin-angiotensin. Right, that's highly, highly implicated in vascular resistance. So angiotensin actually, so one of the models for causing abdominal aorta aneurysms is to infuse that mouse with angiotensin 2. Yeah, just infuse it. And within a few days, you can rupture. You just cause such an increase in blood pressure. And the reason why we do that is so we can study the molecular mechanism behind that. But to your point, yeah, ARBs, are angiotensin receptor blockers, are tremendous. There's quite a few things that are involved in lowering blood pressure, and we generally don't know how to do it. So most people who have blood pressure issues, we have no idea what actually caused it. So about 90% we say have primary hypertension. We don't know what caused it. They just have poor blood pressure control. And so they give a list of drugs, and they start with one drug and they see if that works.
Yeah.
But it's because we don't know if this drug is better than this one, if this combination is this. But I will say angiotensin receptor blockers are really, really good. Something that now it's good in general blood pressure, but blood pressure is regulated differently based on the organ. So one of the main organs of concern for a bodybuilder is the kidneys. Your kidneys actually regulate blood pressure a little bit differently. There's a really interesting diabetic drug actually that doesn't do the best job at lowering blood sugar, but does a tremendous job of reducing blood pressure in the kidney. They're called DLT2 inhibitors. It's an absolutely incredible class of drugs. So they only lower A1C by like 0.5%.
Yeah, right.
But they improve mortality in diabetics. Most of us have been studying diabetics better than any other drug. That's pretty interesting to me. So it tells us that, okay, the kidneys have their own way of regulating blood pressure. And so something's happening in the vasculature there that's maybe different than the heart or wherever
else. Yeah.
And so I wonder then if maybe that would be kind of an efficacious drug to take for bodybuilders. I don't know. See, the question is, does it work in the absence of hyperglycemia? I don't quite know.
But yeah, that was going to be my follow-up question.
I have half of an answer. So there's another class of drugs that are becoming really popular called GLP-1 receptor agonists. You've probably seen the commercials for Ozempic or something like that.
Oh, we don't actually have those commercials here in Australia. We don't get commercials for medications and stuff like that. But yeah,
that's probably a good thing, actually.
Yeah,
it's weird. Yeah, well, these drugs are interesting. So again, it's actually kind of a similar story. They were originally for diabetics.
Yeah.
Basically, they're based off your body produces something called GLP-1. And without going too in depth, it's a gut hormone. Whenever you eat, food gets down into the digestive tract. Certain cells in that digestive tract sense this, and they secrete GLP-1. And GLP-1 goes to the pancreas and stimulates insulin to be secreted. So about 60, 70% of all of your insulin that's secreted is because of GLP-1.
Yeah.
The problem is GLP-1, the kind you produce, only lasts a minute or two. That's it. Life is like that, and it's gone. So they, some smart people saw that there's these lizards here in the US that were biting people and they were making them go hypoglycemic.
Yeah, right.
So they isolated the saliva from these lizards, Gila monsters, that's what they're called. And they found the compound that is doing this. And it turns out it is very, very similar to our own GLP-1. There's only 2 amino acids different. And because of those 2 amino acids that are different, it lasts about 2.5 hours in the body.
Yeah, right.
And so that's the basis for all these drugs. And so now we have drugs that last really, really long times that have the effect of GLP-1. And what we now know is GLP-1 doesn't just lower blood sugar. It lowers blood pressure too, which is really, really interesting how it does it. We don't know. We have no idea how. I'm trying
the mechanism, yeah.
Yeah, no one knows how. We just know it's really effective at lowering blood pressure. And it does this in people who aren't hyperglycemic too. So that's a really good thing. I know bodybuilders are getting really into something called liraglutide. That's a GLP-1 drug. That's a pretty good drug. I'm not gonna lie. The side effects are minimal and the benefits are incredible. Because it has effects that lower blood pressure, it also, we think it's the blood pressure lowering effects, also improve blood flow to the brain as well. It's being studied in dementia research. It's also, there's GLP-1 receptors on your skeletal muscle. It's regenerative to the pancreas. It does a whole bunch of things right now. It has a lot of cardioprotective effects too. There's GLP-1 receptors in the atria of the heart. So a very long answer to your angiotensin is there's a lot of things that play into it. These GLP-1 drugs actually inhibit a part of the renin-angiotensin aldosterone system. I believe it is angiotensin 1.
Yep.
Yeah. And therefore diminishing everything downstream. So maybe that's how it does it. My suspicion is that it lowers sympathetic input. So it modulates the autonomic nervous system, lowering how much sympathetic drive you're getting. And that's pretty worthwhile to know, is how the nervous system is playing into all of this. Guys who are taking cleanse, stimulants, let's just say, you're getting a lot of sympathetic drive, and that just adds to everything we discussed already.
Yeah, it's stress effectively. Yeah. I guess when you were talking about the GLP-1 effects, where does metformin sit in relation to? It's a similar effect, obviously not on GLP-1, but being a GDA.
It's a great drug. I mean, it is incredible. So there's
kind of like how many of these things can you take, sort of at any one time? I guess probably a better question in that, metformin's very popular.
It is.
Taking that and then taking something like this GLP-1 type drug, as well as, an angiotensin receptor blocker. It's like, is there a point where it's just too much?
Yeah. So a lot of the effects would probably overlap, or maybe one would foreshadow the other and you wouldn't see the effect. So if you took like some sort of RAS inhibitor, those are strong. You could very well see the effects of that and not see the effects of a GLP-1 drug on blood pressure, right? But they do work by different mechanisms. So there's probably some individual variability. We haven't gone to the point where we can prescribe all these to do that.
Yeah, for sure. Yeah.
Speculate for sure. So metformin is great, and it works in a very different mechanism than GLP-1. But interestingly, when you start lowering glucose, you also see very similar effects, right? Despite the mechanism. So metformin is also being studied in Alzheimer's research because lowering glucose tends to have a good effect. Metformin can also lower blood pressure too, which is wild. And the way it does this is it's pretty interesting. Now this is in people with hyperglycemia. I don't know if this would work in people who are just normal, but in hyperglycemia, that blood sugar affects the vasculature very, very differently. The vascular smooth muscle, it's kind of like that. The cells that are responsible for constricting vessels. So you have endothelial cells, and then you'll have vascular smooth muscle, and they talk to each other. But when blood sugar is high, you alter the cell signaling pathways. You start to upregulate certain proteins involved in vasoconstriction. Anyone's interested, it's the Rho-ROCK pathway. And it really screws up the pathway altogether. I mean, it changes it completely. And so that's why diabetics have so many vascular issues. That's why amputation is so high. And then that's why blindness, I think 50% of those who go blind are the result of hyperglycemia, actually, because you're altering how these vessels work. So the way metformin lowers blood pressure is actually by reducing blood sugar, which then allows that, we call it vascular smooth muscle hypercontractility. So metformin lowers blood sugar. We start to restore the normal functioning of that vascular smooth muscle. So again, very different mechanisms. I know for a fact GLP-1 does not do this. I tested it myself. I had different vessels, gave super, super high dose of these drugs, nothing. So different mechanism.
Yeah, that's cool. Like I said, a lot of people will be taking, I guess, a lot of these, not a lot of people, bodybuilders that are starting to sort of come about and understand health and its, its importance in longevity of, training and competing, would be taking, like you said, a cocktail of, they take a cocktail of AAS, but now they're starting to take cocktails of, I guess, healthier compounds. And I'm just wondering if there's an overkill in that aspect.
It's a great question. Bodybuilders are extremists, and they have no problem with that to their supplement regimen, we'll call it.
Yeah.
I'm sure there is overkill. So at least when we're talking drugs, the common phrase is the dose determines the poison, right? So the idea is nothing's inherently harmful until you exceed a certain dose. But I think we need to expand upon that and also add the number of different concoctions that you throw together. These can interact in ways that we have no idea.
Mm-hmm.
And, I would be curious if someone was taking, at least in diabetes. And again, the reason why I bring up diabetes is that's the only studies that have been done on this. Metformin has been prescribed with GLP-1. And the only side effects were gastric upset. And that was in about 30-something%. And, that's a well-known side
effect of metformin, yeah.
And as well as GLP-1. So you could see maybe side effects coupling. I'm going to have to look it up because now I'm curious. I want to know if there was actually a more significant decrease in blood sugar with the combination of those two, because they were through very different mechanisms. So, and as far as I know, I don't think you can take enough GLP-1 to induce hypoglycemia, because its primary mechanism is it stimulates the beta cells in your pancreas to secrete insulin.
Yes.
It can only secrete so much insulin. And I don't think they can go past that to cause you to go hypoglycemic.
Yeah, but I guess then a little touch up on that would be when people are taking exogenous insulin, both slow and fast acting, I guess how would then speculating how would that, I guess, you know what I mean? Because this is what a lot of people do. I get consults all the time with people coming to me with sort of these questions, not this in depth, playing into, but, people are using slow and fast acting insulin.
Yeah, that's when things get really complicated. At the beginning, I said how blood lipids, sugar, and pressure all kind of tied together.
Yes.
Insulin actually affects blood pressure. Actually, it lowers it in some organs, raises it in others. It's really interesting how that works. When you start adding more, obviously, this starts to become just an equation that no one has been able to solve.
Of course.
And that's that pitfall that bodybuilders are guilty of. They just keep taking more and more. And at a certain point, reality is going to have to hit them somehow.
Yeah.
And the guy who just had surgery on his thoracic aorta, he also, his blood sugar was high because he's just not a healthy guy.
Yeah.
And he was excited because he thought he could get a prescription for insulin at that point.
Okay.
So it's this dangerous mentality. He's an extreme, but I saw dozens of these guys all throughout my time working at the clinic, dozens and dozens. I probably saw every bodybuilder in North and South Carolina. And
right.
a number of them who fall into that mentality of just more and more. And, they never look great.
Mm-hmm.
They're never the top level guys, right? So if someone is coming to you asking about that, you might just have to tell them, you're in dangerous territory.
Yeah. Well, yeah, because a more new thing, I guess, would be the use of other pathways for anabolism, and being termed, I guess, a safer type of use model, where we're not just beating on the androgen receptor, we're using, other compounds. So you might be using 4, 5, 6 compounds, but they're all acting on different metabolic pathways to, stimulate anabolism. And I wonder if that's where a lot of these things are sort of happening, and, taking all these other health compounds or health things to help mitigate it.
Well, yeah. So anabolism in of itself is just a topic, right? Because it's very hard to get strictly skeletal muscle anabolism. That's generally not, your body's not designed that way, right?
Yeah.
It tends to grow in response to whatever stimuli you give. So it's at least we don't have the technology at this moment in time to say, hey, just grow the skeleton. There are some drugs that, have attempted that, but they have not been successful. They all have off-target effects because designing a drug is really difficult. And I get trying to maximize muscle anabolism as much as possible. But with that, you're just expanding all the other effects that you're going to see. And if you just keep driving anabolism, well, you're going to deal with a lot of issues. Vascular remodeling is probably one of the bigger concerns, because your vessel, everything really is just constantly changing, adapting. You're building new vessels, or they're actually thickening. You have something called the lumen. That's the space inside of these vessels. That's a really important property. And if you can start seeing thickening going in or thickening going out, when these vessels remodel, there's a point where it becomes maladaptive. And you generally see that when you start taking a whole cocktail of things to drive growth, right? You're going to see proliferation in a lot of tissues you don't want.
Yeah, for sure.
So, less is more in this regard, just using a tactful amount, taking what is needed for your experience level, right? Unless you're hitting the Olympia stage, right? You probably don't need to be exploring all these crazy compounds that you probably don't have any business doing that.
Totally fair.
Definitely it's a red flag for me. And I get questions like this all the time. And, my patience is pretty low nowadays. So I just tell them straight, like, look, you don't have the physique to justify use of this compound.
Stuff, yeah. That's completely fair enough. I guess, would something like, traditional cardio help offset a lot of these potential issues that we could run into as bodybuilders and taking all these compounds, because everyone, there's always two camps. It's like cardio good, and the other camp is fuck cardio. So it's like,
well, yeah, I'm in the cardio good camp. Just from a health standpoint, cardio is great. I mean, everything from brain health to organ health to you name it, right? Looking at what's in the blood and what's actually happening to the rest of your physiology, cardio is tremendous at improving that. The problem is the effects tend to go away once you stop doing it. So it does need to be a very consistent thing. And so you could throw cardio in your routine, not so much for bodybuilding purposes. You don't have to think about it in terms of its ability to lose fat. It's actually not that effective at fat loss after a certain point. But it still has a lot of benefit outside of that may indirectly improve your overall health, thereby improving all of your physique goals. So it doesn't even have to be crazy amounts, but cardiovascular work, absolutely. Actually on everything from blood lipids, sugar, and pressure, it's going to improve all of those. Even if you eat a meal and you go on a short walk, not even a brisk walk, it's incredible how that lowers your blood sugar. Like a 10-minute walk post meal or something along those lines. Yeah, because so I was at a talk, and they did this interesting study where they actually put glucose monitors on people. I don't know if you've seen them. It's this little thing that actually actively measures blood glucose levels. Yeah, and the data is really cool. And just a light walk after eating, it's incredible how that lowers blood sugar after a meal. Unbelievable. Oh.
Yeah. Well, is there any sort of recommendation, I guess, in terms of like amounts, or is it sort of person dependent when it comes to
so that's
utilizing cardio?
That'd be tricky because, obviously the bodybuilding goals would take priority. And so if cardio is already part of that plan or not part of that plan, that's probably going to have the biggest influence. For general health, however, so separating it from the bodybuilding side, yeah, there are recommendations, and it's nothing crazy. It's like 20 minutes, 4 times a week.
Yep.
On average. Depends what study you read, but if you average all of them, it comes out to about that.
Yep.
And it's not even getting your heart rate too crazy high or anything. So it's not a huge ask to do a little bit of cardio. And really, the human body is meant to move. You should be able to do this with no problem. And it should not negatively impact your bodybuilding goals. That would be ridiculous. If 20 minutes of cardio 4 times a week, you start losing muscle from that, that's a diet issue.
yeah.
Something else.
Other problems there.
Yeah.
Well, so say thanks for jumping on, man. It's been a really good chat, and hopefully we can get you on soon, talk a bit more PED stuff, because I feel like it's an interest point for yourself.
Yeah, hopefully people found this interesting and took away some good info. I mean, I know it's a lot. Maybe I should write up a little summary.
That's all right. I've got someone that will probably look at doing some stuff.
Oh, perfect.
But
Excellent.
Yeah, man, it was really cool. Like, it's a really good chat and interesting chat in working out, I guess, what blood tests you could ask for coming from somebody that worked in clinic and, did that.
Yeah.
It's a lot different down here. I think, I don't think it's so much different in that the actual reasons as to why you can and can't get them, but it's cool knowing, I guess, what to get, because the doctor will never tell you to get any of those.
They never will. They probably don't know either.
Well, even then. So
there's quite a bit. Actually, one last point on kidneys, because I didn't touch on it. This was always a big concern, is looking at GFR as a blood marker. It is actually not an accurate measure for bodybuilders. Glomerular filtration rate is not always the best for people with high muscle mass. So there is something you can take called cystatin C instead. That's another kidney test that I'll look at, kind of give you an idea of how much fluid is being filtered in the kidney, but it does take into account muscle mass. So it's a little bit of a better marker for bodybuilders. So just we could add that to the list.
And even better, the more the better. Usually finish off with a question that seems to stump a lot of people, but I feel like it's pretty straightforward. It's just 3 Instagram accounts that you follow. They basically give you a good laugh or sort of help you get through your day, especially when you're dying and stressed inside the lab, or when you want to kill everybody.
Yeah. So, I post really random content on Instagram.
Man, your content's good. The circadian stuff was really, really interesting.
Yeah. The circadian stuff is great. So yeah, whenever I'm like running a centrifuge, I have 15 minutes to kill. There's a few, and mostly they're political accounts. Because I try to get my information not from the mainstream media, but I want to know what's going around the world. And that's tough to do. So I actually have my phone here. I have 3 Instagram accounts. That should be easy. Well, I follow a lot of medical stuff, but
that's fair.
Inside History, such a great Instagram account. They just do like historical stuff. I like DC Drano. He's this guy, I think he was a lawyer at one point, and then he left that, and now he just makes fun of Joe Biden, essentially.
Fair enough.
Yeah. And then Garbaggio. Oh, okay. You know what? Let me give you one more. Garbaggio News is great. Biased as hell, but it's funny nonetheless. Hilarious. But one guy who I draw inspiration from is Ian Smith Fitness. You guys might know him. They tried to shut his gym down with all the COVID restrictions, and he said no. Yeah. And that's what I love is he said no, and he's willing to take all the shit that they throw at him. And he is not faltered one bit. And it's really refreshing to see someone like that who they believe in what their values, and they're not going to be coerced or bullied into giving up their rights and freedoms. And so by all means, Ian Smith Fitness, great inspiration.
Fair enough, man. Sounds like an interesting account. I do actually follow Ian Smith Fitness.
You follow him?
Yeah. I have seen some of the stuff he's been putting up over the last sort of 18 months. So it's been crazy. Crazy times.
Yeah. Crazy times. I don't see them getting any better.
No, I'm with you on that one too, my friend. I think we're a bunch of pessimists. So
I've become pessimist over the past year. Yeah, I don't know how you guys are doing it in Australia. I would have built a raft and just float it out.
We sit here and just like we take bets and sort of just like by gauging case numbers per day and stuff, and we're just like, yeah, get ready for the announcement. Here it comes.
Jesus, it is.
Anyway,
Well, that's a whole nother conversation, but
that's totally fair.
Yeah.
But anyway,
well, I hope things turn around. I hope the restrictions loosen up a tiny bit.
Let's hope. I'd say let's pray, but I don't think that's going to help much.
There won't.
Thanks for jumping on, man. It was a great chat.
Anytime.
We'll definitely get you back on soon.
Cool.
And thanks to the listeners, as always, for tuning in. Catch you later, man.
All right. See you.